Welcome. This is the meeting of the Patients and Committees Committee of the Norfolk and Waveney ICB. Just a reminder that the meeting is being recorded for minute-taking purpose as well as for records to go on a website. This meeting is in public, is not a public meeting, it's held in public. So anyone who couldn't join us today will be able to still see the recording of this meeting. Just as a reminder also that we don't have the time to do introductions around the room, but if when you speak, present, ask a question, whatever that is, please can you introduce yourself so we know who we're talking to. So the name and the job, please, and the organization you represent. So I think this is all the sort of not quite health and safety, but in that field of work introduction, and we will move on to our substantive agenda items for today. If anyone is new to the meeting, my name is Aliona Deret and I'm the chair of this committee, and I'm an independent non-exec member of the ICB board. Okay, so Rachel, with your permission, please, may we have any apologies? I think you have a couple.
Yes, so apologies from Emma Ratzer, representing the VCSE Assembly, but Mark Hitchcock is here representing Emma, and also Sudan Meredith will be 30 minutes late joining us. So that's it for today.
Thank you, Rachel. Welcome to Mark, and I saw some other people joining us. Welcome to everyone who joined after I started. Declaration of interest. The register has been circulated in the papers. Again, a reminder, we are taking papers as read. They have been uploaded to the admin control, and we take them as read. So the presenters, we are asking you, if you have a presentation, to share it and drive it, but please do not go through every slide. We're looking for the key messages from your topic so we can have time for questions and discussion, please. Going back to declaration of interest, was the register circulated? If during the meeting you feel that you have a new conflict of interest which comes through, please put your hand up, declare it so we can register. Thank you. We'll move on to the minutes of the last meeting, which took place on the 22nd of July. It feels like ages ago, but it's almost ages ago. Rachel, thank you so much for pulling them all together, very detailed. Thank you. I will ask the committee first to highlight any sort of accuracy issues within those minutes. So I'm not taking any martyrizing, it's just accuracy of the minutes. Do we have any feedback from any of the committee members on the accuracy, please? No, I can see negative nods. So based on that, I will take them as a true reflection of the conversation we had. Rachel, thank you so much for drafting them for us, as always, very detailed. Thank you. Matters arising. Any matters arising from anybody? I can't see any hands up and I can't see any desires. Any questions? Okay, so I will take that as no matters arising. Thank you. Action log. Rachel, are you happy to share with us, please, the action log?
Unfortunately, I'm having a few issues with sharing my screen at the moment.
Okay, there's one action. Again, the committee members should have read that action. Is dementia awareness training, and I think we're going to have an update as part of our presentation to them. Thank you so much, whoever managed to share that. Well done, thank you.
I snuck in for you, Rachel.
Thank you, Frankie.
Thank you.
We're going to have an update on it in a minute. So
yep, but the question was very much have we delivered it? How many to? So that is the update.
Yep,
so the sessions have been done.
And we have the update here. So may I propose that we close the action? Thank you. Now over to the risk register, and I will invite Mark Burgess to take us through it, please, Mark.
Thank you, and I'll be brief. Hi, thanks, Aliona, and good afternoon, everyone. For those that don't know me, I'm Mark Burgess. I'm the Exec Director of Patients and Communities for the ICB. So I will take the brief paper as read, but I think it is an important one for committee members just to digest, please, because we have done quite a bit of work on this over the last couple of months as a wider piece around risk and how we manage it as a board, as an integrated care board. So there are two risks as highlighted in the paper that are particularly pertinent and with oversight from this committee. The first of those, the Board Assurance Framework 01, which is around the health inequalities and population health management. And the risk highlighted there around us not meeting our statutory duties, particularly about reducing health inequalities and how we use population health management to its greatest potential. So included in there are some of the controls that we have in place and the assurance on those controls, and importantly some of the gaps as well. So that's I'm sure this committee will agree is a very pertinent one for us and our work. The second is around the increasing numbers and the complexity of conditions for some of our older people across Norfolk and Waveney. As an example, around the pressure on services, of course, more care typically increases costs as well, and that's something we need to be very mindful of. And more importantly, perhaps the quality, there is a risk around the quality of care declining if we don't do everything we possibly can in that area within the constraints that we have. So they're the two main risks that I'd like to flag to the committee, and the work in that we are doing together to try and make sure that we mitigate as many of those as we can. I won't say any more on that. The other thing that we'd like to do as a part of this process is around our operational risk register. Some of those that we'd had on previous risk registers are included in this board assurance framework update here, but there will be further risks that we will highlight as a committee going forward. But if I pause there, Aliona, but very happy to take any questions as always.
Thank you, Mark. You already preempted my question about operational risk, so we're waiting for them. I will open to the committee for questions on either of the two. Tracy.
Yeah, not really a question, but more of a comment, because at the moment with BAPO1, we do report that directly to the Population Health and Inequalities board. So you get additional assurance in respect of that with the insurance report that Frankie presents to you. But what we're doing in respect of that risk, so working very closely with the Population Health Management Oversight Group and the Health Inequalities Oversight Group, we've got a date booked with the corporate governance team in order to review our risk, in order to work on, as Mark has said, around those operational ones and the more strategic ones, because obviously with the health inequality strategic framework for action, it is a strategic framework for action with those three pillars. So we're going to do a piece of work around that, just so that you're reassured. So that will come back to here in due course.
Thank you, Tracy. So on the back of that, my question was going to be around the gaps of controls in this, and there's about 5 areas. Can we get the reassurance that those 5 bullet points listed in the gaps of control section of detailed risk register are being picked up and there's actions against them and we have a plan?
Yep, I can absolutely say that there is, certainly aligned to the Health Inequality Strategic Framework for Action and the Population Health Management Strategy. They've both got implementation rounds around them, and certainly some of the wider work around place and how we work in respect to that. We do have some detailed planning behind those to kind of close those gaps. And I think at some point in time, those dashboards and some of that data will come here, because we've got some really great work going on there with the teams.
Thank you. Mark, on the same vein, I'm going to ask about the second BAF risk of 5, where the gaps and controls are. What reassurance you can give us that they're being picked up? I know the place work needs to happen, and I'm sure it will not be very long before we get a full update on the place governance and so on. But as that is developing, can you reassure us that there's sufficient work going on to progress?
Yes, I think I can, and Frankie may want to come in as well to add to this, but particularly as you've highlighted around the place-based elements and making sure it's coordinated. I think that there is the HIOG that oversees this as well, but we do need to make sure that it ties in with place colleagues. So there's work to do, absolutely, but I think we've got it covered off, and I know we talk about it regularly. But Frankie, you may want to add some more detail from your perspective as well.
Thank you.
Yes, thank you, Chair. It's a lovely question, because I think today's agenda will address it in two different ways. Firstly, in our spotlight on dementia, by having the focus on North Norfolk. Actually, this is our delivery. You know, the system-wide strategic work is one thing, setting the aims, the outcomes we want to get to, but where the real work is done is very often at place level and at integration neighbourhood team level indeed. But secondly, the paper from the South Place later on, again, you know, really poses that example of what we are already doing together and what else we'd like to be able to do. So I hope those two will both give you assurance in different ways.
Good. Thank you so much. Thank you both. Any other questions for Mark on either of the two risks, please? No. Okay. Thank you. And thank you to getting to this stage, Mark, and we'll look forward to see the operational risks soon, hopefully by the next meeting. It's 2 months' time. Yeah. Good. Thank you. Okay, we're moving on to the item Frankie just mentioned, Spotlight on Dementia. We're running a few minutes ahead, which is good, because the Spotlight on Dementia, we have 4 items and half an hour now. So I am going to cut short if I feel that we're overrunning, but I'll do my best to make sure we cover all of them properly. So without any further delay on that, we're going to start looking at the issue of dementia, provision, different perspectives, and so on, with inviting Liz. Liz, I think you're going to share your experience from your personal experience with your mom. Is that correct? So
yes.
I will leave for you to introduce that part. Liz, if we sort of 7 to 8 minutes.
Okay,
time,
I'll do my best.
if that's okay. Thank you. Welcome, Liz, and thank you for coming today. Yeah.
Hi, well, I'm Liz. Some of you know me because I'm also involved in that Norfolk Health and Wellbeing Partnership and various other dementia pathways. But I'm here today because I'm a full-time carer. Well, not a full-time carer now because Mum's gone into a home, but until very recently, I was a full-time carer for my mum, living with me for the last 11 years. So I'm just going to go through some of that experience at a very rapid rate and identify what I think some of the issues are. I also work locally with Sheringham Dementia Friendly Community, and I do dementia awareness training in the community. So the issues that I'm having are not dissimilar to those of many of the carers that I work with. So moving rapidly on, Mum was diagnosed in 2008 with vascular dementia. I'd managed to move her to Sheringham into a little flat from Norwich, and she was doing okay, but we knew there was something going on. So we decided we would start the process for getting her assessed and determining what was happening. It was 6 months to complete the process, which wasn't too bad when you compare to where we are today. But we were left with no further sort of follow-up or where to go or anything. So that was quite problematic at the time. We managed Mum at that stage in her own home quite closely. We did things like we'd have to ring her 2 or 3 times a day, and I'd have to say, oh, it's your lunch group today, Mum, off you go, it's your hair appointment. We live in a really close community, so like our hairdresser would ring her 10 minutes before, etc. So we managed her in that way with a lot of support from the community as well, and she was quite safe. You know, things like you had to go and clean her fridge out once a week because there'd be microwave meals in there from 3 weeks and that kind of thing, which, you know, no, that was only yesterday. So, you know, that kind of thing. But gradually, as she became more and more anxious because she didn't know where she was supposed to be or what day it was or what was happening, she started spending more time with us as a family. And she'd just sort of appear at 11 and not go home till bedtime, that kind of thing. Which was fine. But then in June 2013, she became poorly with an infection and became very ill. we literally had to carry her out the house, first of all, to us, and then I had to get ambulances, and she went into the NNN. So she went in with as someone who was living independently with a lot of support, family support, and 10 days later wasn't capable of looking after herself anymore. Her dementia had deteriorated so rapidly and so quickly. It did throw us into crisis, and I think this is a pattern that's very true for a lot of people. I hadn't been aware until I later did my training that with vascular dementia, it's often a very dramatic drop when you get an infection or there's some kind of trauma. And that was a situation we were faced with. So we had 10 months of mum sharing my bedroom till we could get planning permission and all those things sorted so that we could create space for her in the home. And it was really it was a very difficult year, that first year of having to look after her. Had I been more aware of that was possibly the potential, I think we would have done things earlier and planned things earlier, and we wouldn't have gone into that crisis. And I had 2 teenage boys at the time as well, so it impacted on all of us, and doing exams and all the rest of it. So it was a difficult time. So I then became a permanent carer for mum. Initially, I could leave her for a couple of hours and go off and do things, but that changed quite quickly. And as a family, it was difficult because where I went, mum had to come. Where I went with the boys, mum had to come. And when they went off to university and things like that, going away and seeing them for a weekend, because there was no respite, there was nothing available. That was, take mum with you and all the problems that came with that. So my mum is, she's always been really busy, very active, and done all sorts of, quite high powered jobs and run businesses and all sorts of things. So it's a very different thing to come to terms with, that your mum is almost now your child. It was like having a third child and going back to toddler stage. So by 2022, I was really beginning to really struggle. She did still do an awful lot of things with me, and she's really well known in the community as a result of it. She's known as Nanny across the whole of Sheringham because so many people know her. She would come to meetings with me. She would come, if I was going to a coffee morning event, she would come with me. She would, she was part of my work life as well, which was, very, very generous by a lot of people have been allowing me to do that. But it became increasingly difficult. And by 2022, I was getting quite desperate. I tried to get in a social services assessment at that point. And I started early in the year, couldn't get any responses, couldn't get anything out of them. And in the end, I had to start paying for her daycare at a local daycare centre myself. And I paid for that for nearly 8 months myself before we got anywhere with that process, which put an increasingly difficult financial burden on me as well, because trying to fund that, I'm actually retired from work and only have a pension, but I'm not on a state pension. So, not living off a huge amount of money, and put a lot of pressure on us, and no capacity to earn more because I was a full-time carer. So we got to the stage then where we couldn't leave her alone at all, which, you can see your world around you shrinking, and it became harder to take her with me. So my world became much smaller. I was still taking her with me to some things, but having to fit my life into the 2 days that I was paying for at daycare. And then we hit a real crisis because, as isn't often the way with carers, as you all know, I became ill, absolutely worn out, got pneumonia, and ended up, well, they wanted me in hospital and I couldn't go because there was no one to look after mum. I had friends who were trying to get through to social services to get respite. It was almost impossible, spending 4 or 5 hours on a phone trying to get through. And eventually I became so ill that the ambulance was called and I was taken in really poorly. I made it really clear in the hospital that I was a carer, that there weren't people to look after my mum. I went through 4 different wards, and every time it was made clear that I was a carer, and people were struggling to look after my mum. I had friends coming in. My son came back from Leeds to try and help, and it was a really, really difficult time when I should have been able to concentrate on getting better. And when I came home and I was discharged, even though on the last day I said, but I'm going home to look after an 87-year-old lady with dementia. I can't even get myself to the toilet at the moment. How am I supposed to do that? And there was nothing there. And it was only, it was about a week later, we finally got social services, and they gave us a week in respite for mum. And then I was back to it again. So it wasn't easy at all. We carried on. November, December, mum by now is doubly incontinent. She started being awake most of the night. So I was getting up 2-3 times a night to sort out, and when she was wet, and change pads, and when she was wandering and thinking it was first thing in the morning and time to get up, and it was only 1 o'clock or something like that. So I was having 2 or 3 hours sleep, and most of that was disrupted as well. I knew, and from everything that I'm involved with, I knew that I needed help. So trying to be sensible, I contacted social services in the January and said, we've got to the point where I don't think I can manage anymore, and mum needs to go into a home. Now, that is a really, really hard thing to do anyway, and to say that. And at that point, I needed someone to pick me up and say, okay, let's get this sorted. That didn't happen. I had to constantly call back. And when I say call back, it's almost impossible to get hold of them, because the only way you can do it is to go on their email and do another complete referral system. And it got to the point where I do them and I just write on it, you've had this information before, you've had this information before. Because I didn't, you can't sit there for another 45 minutes and fill another referral form in. You just want someone to call you back. We finally got somewhere in July, after I'd had pneumonia again, and again there had been no respite, and actually I didn't have the same level of support around me, so I couldn't actually go into hospital, even though that's where I desperately needed to be. So we managed through that, and it was only in this summer after that that we got mum in, and she's gone into Tamar House in Cromer, who straight away understood exactly what my situation was and couldn't have been more helpful. And actually, if I hadn't had them fighting my corner to get the final assessments done, I don't think it would have happened. And they ran for several weeks without having an agreement that they were going to get money, because it was just very, very disorganized. So I think it's finally been agreed this week. So that process started in January. 7th of January was the first day I rang and sent an email, and it's just been agreed this week. She's been beautifully well looked after. I won't say it hasn't been traumatic. It's been hugely traumatic. We've had huge adjustments in our lives, because my whole life was dominated by mum, and even my children's lives. Even Jack, from who's living away in Leeds, has had to come home. He's moved into his second new house, and I haven't seen either of them because I can't go. Now I can, and we're going up shortly, but that's been the reality of it. And I do feel really, really let down. And I'm someone who knows how the system works. I'm someone who knows how to call people. but it felt like there were secret numbers, and unless you bumped into someone who actually had those secret numbers and you could get hold of people, it didn't happen. I don't feel the discharge processes work in hospital. It was always someone else's job when you said to them, I am a carer. My mum is being looked after she's being looked after, but it's not proper care of her, and it's very difficult to manage. And, you know, what's going to happen when I go home? It was always someone else's job. Oh, the next ward will sort that out. Oh, that's so-and-so's job. That's the discharge team. No one ever actually did anything. So that pathway, and I'm not the only person that's been through that, that pathway I don't feel is working. So the 4 issues that I've pulled out that I feel need looking at is the fact that you have a social worker and it's for one little item. It's for that week of respite. And then they say to you, oh, I'm not your social worker from tomorrow. So you'll need to call in and make a new referral and start the whole process all over again. And when you are a full-time carer in that sense, you need that support, you need that connection. So, you know, that for me is a huge thing. And, you know, I've had a super lady who's helped us through the last couple of months. But, you know, I've said goodbye to her again last week because she's gone, and I know if there's any more issues again, I've got to start all over again. I think the portal is very difficult to manage, and particularly once you're into it, there's seems very few ways that you can actually find out what's going on with your case. You've not heard anyone for 3 months. What's happening? You know, you've got to go through that process all over again. So I think that needs looking at. And, you know, for people who are not online, it must be horrendous when you've got an old couple and they're trying to look after somebody as well. Respite. It needs to be planned for people. If you're going to prevent, you know, I think if I hadn't got mum into a care home, and this isn't a dramatic statement, it's genuinely how I feel, and I'm a different person to what I was 4 months ago now. If I hadn't got mum into a care home when I did, I would have gone out in a box before she did. That's how far we were pushed and left unsupported. And I genuinely think I probably would, you know, I would have been either very, very seriously ill or not here, because I was really on the edge. So planning that respite in is so important, and trying to get some emergency system that's working for people when you do need it, and following that through with discharge, because it's certainly not happening at the moment. And I'm seeing one of the things I deal with in health is showing them, and one of the things they want to look at within that is unhealthy, you know, and unsafe discharges, because people are coming back into our communities who aren't capable of being on their own. So those are the 4 points I think I'd like you to take from what I've said today, and help you understand the some of the difficulties that people do face when they're full-time carers.
Liz, thank you so much. Very kind and brave of you to share that with us.
Fine.
I can only imagine what it must have been for you, and I hope that your mom and you now get sort of the type of care you need and time for yourself. But you have very kindly pointed out very, very important things for us, and I hope that those are being picked up already. I hope that this has been flagged up before and they're being picked up through all the kind of works we are doing. I will just ask, I'm going to ask my colleagues if they have any questions for you or anything they want to say, but there is work happening on dementia currently at the ICB level and system level, and we'll hear about it more in a minute. Are you involved in any of the work streams?
Yes, I'm worked in the dementia working group for the Northern Place one.
Okay, thank you. Is experiences like yours, which are fundamental in helping us, making sure that what we go forwards with is the right thing for people. It's one thing to see the piece of paper in an office somewhere and make it up, and it's a very different when we listen to people and learn from their experiences. And actually, we produce what will work for our population, not what we think may work for the population. Liz, thank you again. I will go to Tricia. I can see your hand up, Tricia.
Well, thank you so much for sharing that. I don't like using the word story because it's more than a story. It's a catalogue of where things could have been done better to support not only the family but your mum and the community. There were a couple of things I wanted to acknowledge though. The discharge pathway, yeah, it's not working as it should, but there is a lot of work that's going on to improve that across the system, but it hasn't had the impact yet that we need it to have. But the other point I just wanted to delve a little more into was around the support as a carer and whether anybody talked to you about the carer's passport on your journey. Was there anybody that was put forward as a care coordinator? Anything of that nature?
I had following. I found out about carer's passport myself, and I had through the work that I'm doing in the community. So I had that, and I actually had that. One of my friends, as I went off in the ambulance, because I really was incredibly poorly, actually, because it's on my work
Badge.
work badge. She actually put it around my neck, so I arrived in hospital with that on.
And it still didn't provoke the response.
It still didn't provoke the response.
Yeah.
But I did also have a Carers Matters phone call, probably about May time, and I had a long chat with that lady, and we discussed everything that was going on. And she herself tried to get the process moving in terms of mum's assessment, but wasn't successful even from that angle.
And then finally, I think what you describe as a tapestry of handoffs between different people and not being able to get through on phone lines, etc. That is something that we need to make better, because if we don't provide a responsive service, then how do we build the trust and confidence that we're actually listening? But thank you very much.
I don't know whether today's been recorded, but I'm more than happy if anyone wants to use it, if it was recorded, for you know, as a case study as such, to support you in what you need to do.
Thank you. I'll come to Tracy and Karen. I'll just ask for quick questions, quick responses. But Liz, in your when you were talking, you mentioned about the portal. Is that the portal on County Council website? Okay, just for clarification. Thank you. Tracy and then Karen, please.
Yeah, I'll be quick. So thank you, Liz. I'm Tracy Williams. I'm the ICB's Clinical Lead for Health Inequalities and Inclusion Health. So thank you very much for sharing your experiences. And, you know, it does make me really sad to hear what you and your mum, you know, the experience that you had. And from my perspective, and you said yourself that you understood some of the systems and some of the processes and what was happening, and this is your experience. So what about, you know, how do we hear those voices in some of our communities and our carers who won't understand the system, who won't have a voice, and what can we do more to support those carers in those circumstances and their loved ones? And from your perspective, what can we do? Because I know our systems are really, really complex, generally, just to understand.
Yeah, I think it's a very difficult one to do, I think, because the most people aren't actually even connected with Norfolk County Council, so they don't even really know that route is there. So I think it's about getting those messages out into the community groups that are doing this kind of support work. You know, the community supermarkets are often running groups alongside it and that kind of thing. And I think there's got to be a really concerted effort to get that information out into the community, so that people who are supporting the people already in the community and probably are known to them, you know, the daycare centres and those kind of places, that they know what the route is very clearly. There has to be a very clear pathway that's got those contact details on it, and then people can actually say, well, this is what should be happening next, and support people to do that as well.
Thank you, Karen, and then Mark. If we can be succinct, please.
Yeah, thank you. Yeah, thank you very much, Liz. I'm Karen Bryant, Associate Director of Commissioning for the ICB. It's a new role, but part of that role is sort of looking at opportunities to working with sort of Norfolk County Council, Suffolk County Council, just in terms of that joint approach. How can we do better together? And I think carers is certainly something that I'll be picking up with them when I next meet. So thank you very much, Liz.
Thank you. Mark.
Thanks, Sally. And so I'm Mark Hitchcock, standing in for Emma Ratzinger for the VCSE Assembly. Liz, we met recently.
Yeah.
I was just wondering, I know this is a question for the room rather than just for Liz. She's offered to kind of use this testimony. Is there enough, or is there any root cause analysis that we can undertake? Because for somebody like Liz to get that sick with her knowledge of the system, I think that's quite concerning. For there's been an awful lot more people in Charing that haven't got a clue how to navigate it. So if there's any help, I'd offer to sit in a room and try and go through that story and understand the process. I'm a trustee of Voluntary Norfolk. I'd like to hear Carers Matters working for everybody as well. So if anybody's interested in taking that up, then I'd be very happy to offer the time. Thanks, Aliana.
Thank you, Mark. Thank you, Frankie. Are you going to come on that?
No, not directly to Mark. I was just going to echo the thanks to Liz for sharing such a personal experience, but also to say that unfortunately you're not alone. And in fact, we're holding a very small, well, it's got a lot bigger, but the idea was it was going to be a very small roundtable event this week to go through a few personal stories to really map out actually where are we not serving our community, where are there gaps in the pathway, because in fact there is no pathway to support people diagnosed with dementia. So we need to address that. But just wanted to thank you, Liz.
You're welcome.
Thank you. I can't see any more hands up. So Liz, a big thank you from us again. And I do hope you'll stay involved with the relevant people to help shape this pathway. We need to sort it out. Thank you, Liz. And our best wishes to your mom, if we may, please. I will move on to Alex and Andy, Healthwatch perspective. Gentlemen, may I ask you for a succinct report on that, please, so update and view. Just try and stay within the time limits, which is running away. Alex, Andy, yeah.
Do you want me to kick off, Andy? Okay. So yes, unfortunately, Liz's story is not by any means a lone story. We know that in Norfolk and Waveney, that 11,030 people over the age of 65 have received a dementia diagnosis. That said, the estimate is there's a further 17,946 people over the age of 65 living with dementia, according to NSH Digital. All people with dementia are supposed to have an annual review with their GP, where the doctor should ask questions, review medication needs, etc., check for new systems. But actually, that's only happening to about 39.2% of people at the moment. So I put in the chat, Healthwatch are currently involved in a fairly wide study about this at the moment. And so far, the dementia context is so widespread and people and their carers are so severely affected by it. We wanted to better understand the experiences of people with dementia in Norfolk, as well as those of their carers, in order to discover how they might better be supported. So the things that have come up that people feel very challenged with are A, knowing more about dementia, B, planning for the future, being supported to be involved in decisions about their lives, maintaining relationships and connections to their local communities, support being offered to carers, managing behaviours that others may find challenging, and living positively with the risk. Last week, the Alzheimer's Society held an event in the Forum, and there were a myriad of stories and studies that were presented at that day, many of which are on film, and I'm sure they'd be happy to share them. But one particularly poignant thing was when one GP turned around to the family and said, "I suggest you go home and make a will." You know, the way in which that whole issue is handled is really quite appalling and very, very uncaring, however tired or traumatized the general practitioner may be at the time. So, I mean, I suppose just to conclude my little bit is that we've found that a significant proportion of people feel alone. Again, Liz has alluded to that. And there's insufficient help to alleviate and meet their needs. People want more information on the progression of their condition and on who would pay the cost of care, regular check-ins from professionals. Some people have mentioned problems with care providers, particularly domiciliary care agencies, performance in caring for people with dementia, and a mental health condition that can be associated or allied to that. People with care needs and their carers also reported very high levels of isolation. So the other thing I would have shared with you, and I'm quite happy to post it to Rachel, is a video that was actually, it's 10 years old, and it was an Inside Out video, which Harold Bodmer, for those of you who will remember him, featured in it. And what's very, very sad, I watched it this morning knowing that we were going to be talking about this afternoon. And I couldn't play it because we haven't got permission from the BBC, but I can share it. It is that really nothing has changed in 10 years since this last video was made, which I kind of think is a complete travesty. And for those of us who work in the system and find it difficult to wade our way through it, God help those that don't, at which point I will shut up.
Alex, thank you. And if possible, yes, please, to the sharing. The figures are worrying, aren't they? And the experiences are worrying. So just about the right time to get on and do something about it. I'm sure we all agree to that. Too late, but it's better now than never. I'm going to go to Alex, to Andy. Andy, from your perspective, please.
Thank you, Aliona. First of all, Liz, what you said, if only all the thousands of people in Suffolk who were in your position knew that you were talking about your experience today in amongst NHS and other partners, if we can get that story out, then they may want to come and share their stories locally as well, because whilst your story is incredibly powerful and insightful, unfortunately, we need more people like you to talk about this more often in more places in order for change to really happen. Aliona, I won't be saying anything. I've invited one of my colleagues, Susan, to talk about some work that we've done in the recent past. Thank you.
Thank you, Andy. Susan, please.
Hi, yes, I'll try and keep it short. I'm Susan Bailham. I'm a research officer for Healthwatch Suffolk. Again, I'd like to thank Liz as well for sharing your story. It really resonated with a lot of the things that we heard within the work that we did, particularly around that lack of support after the diagnosis and that feeling of being left on your own to cope. The gap of support from social care, particularly for those who were self-funders. People felt that they weren't given the same level of information and advice. And particularly around moving into a care home and the support actually people need around that. It's quite a traumatic time for everybody involved, the families, the person moving in, and for the care home as well. They're taking on a new person with, unknown behaviours. So, there's a lot of support needed there. So our work we did back in February 2022, it was, we were approached by the Suffolk Dementia Action Partnership. And the purpose was to understand what was working well and what was not working well and for improvement. We were looking across the whole dementia pathway, so it was a huge piece of work. And the aim was to feed into the development of a Suffolk Dementia Strategy and Action Plan. We heard from over 150 people who shared their experiences with us. We had 100 people who filled in a short feedback form with us to give us some broad insights. And then we interviewed in depth 19 people, either family carers. We did interview a couple of people with dementia themselves as well. And we also looked on our feedback centre for comments. We took all that information, we themed it all and published our report. And I put a link to our webpage, which is all the information on there. including a couple of videos as well, which people might like to look at. Our report is very heavy with quotes because that was quite a conscious decision. We really wanted people to understand that this wasn't our interpretation of what people had said. This was actually what people had said had happened to them. And like Liz has just shared with us, it's how it made them feel actually as well. It's not just that they're not getting phone calls, but actually how does that make that individual feel when they're not getting answers from people? If you look on that webpage, we made 26 key learning points across 7 main areas of the dementia pathway. And we also created a poster outlining the top 5 messages we wanted to draw people's attention to. So I'm just going to go through those. So people wanted someone to guide them to support. Actually, they said that quite often there's a lot of information there out on the web if you put in dementia, but actually finding that bit of information that you need for your particular circumstance at that particular time is really difficult. And people wanted more help with being able to find that. People wanted to be taken seriously when they asked for help and not just feel like they were being dismissed, and that they were recognised for the knowledge and experience that they have. This was particularly from family carers. They knew their relative, they knew how they should be behaving, what they liked, what they didn't like. They didn't feel that that was always recognised within support plans and care plans, or when an individual was taken into hospital. Wasn't always listened to. The importance of continuity of service for people with dementia, to be able to build those trusted relationships, was a big issue that came through in our report. We all know that hospitals are a difficult environment for anybody, but particularly for those with dementia. So the need for improved access to services that prevent admission to hospital, as well as supporting people back home, was needed. And picking up again on what Liz has talked about, people wanted services that work together, drawing on each other's skills and knowledge that work with them and not against them. And, you know, we had a few examples of that, people feeling like they were ping-ponging backwards and forwards between different services, that they were the linchpin that was having to make all the phone calls, make those connections, and say, but this person's told me this, and, you know,
Susanna, I'm sorry, we're running out of time for the item and we still have 2 presentations. Would you mind just giving us the summary? We can read it. It's just a little bit more concise, please.
Yeah, okay. So that was really all I was going to say in terms of the findings. It's all there on the website. Our report poster, there's a key summary document as well. And yeah, this has all been incorporated within the Suffolk Dementia strategy and the action plan.
And is that published now?
It was published in May, the actual strategy. I know work is still ongoing on the action plan. There's a couple of meetings this week, but I think Gail Cardy is hoping to have that available fairly soon.
Thank you. Thank you, Suzanne. Andy?
Just one other point, Susan, about CQC's actions since we published.
Just to say that they've also picked up our work. They've taken that forward. We've linked them with Peter and Teresa, who feature within one of the videos that we show, and they're building that into their own dementia strategy as well.
Lovely. Thank you, Andy. Thank you, Susan. Do we have any further questions to Health Watch in general? No. I am sure the pieces of work the reports you shared will be picked up by our colleagues Sunday. Frankie, I'm looking at you, but I'm sure Janice Shirley, who is holding the responsibility for this work stream, isn't it?
Who's next on the agenda?
Who is next on agenda? Exactly, is going to take note of all of that. So thank you all. I will move to Janice now, and we're going to have an update on dementia work stream, please.
Hi, thank you for inviting me.
Hi, Janice.
I will be very quick because obviously a lot of it was on our progress reports. And also Frankie did actually mention that we are holding this roundtable event on the 25th September. Obviously Liz's story as well is added to the Herring experiences that we've already been collating about patients and families and carers accessing care for dementia patients. So the event will actually help us explore more of the details and depth and identify what do we need to change across the whole of the ICS to sort of like improve care for patients living with dementia. And we want to sort of like be able to collaborate services around the patient so that we can improve outcomes and experience. So that's happening on Wednesday, and my colleague James Allen, who has recently joined the programme, he's going to be leading that event. And also we have also got some new specialty advisors that have joined the ICB, Drs. Katie Honey and Dr. James Casson. They're currently consultant geriatricians over at their QEH, and we're delighted that they've joined as specialty advisors for our programme for frailty, older people and dementia. So that's going to be a really exciting event, and I do hope that we can actually make progress following that workshop. Obviously, we're pushing on the dementia charter. Organisations are completing their self-assessment forms and doing their gap analysis, and we will be continuing to work ourselves on developing the dementia dashboard. Also, Katie and James are going to be working on new innovations to sort of like help with identifying patients earlier in the process. So they're working with the UEA, looking at screening software for cognitive decline. And also we sort of like continue to look at the use of R's roles to sort of like fund new roles in primary care. So there's a lot of work that we're doing. We've got a new team and we're really excited to push this forward. So thank you, and we look forward to working with you, everyone, to improve care in this area.
Janice, thank you. A couple of questions from me, if I may, please. In terms of the biggest challenge at the moment, as you are going through with the work of the work stream, what are you finding to be sort of the current biggest worries you are facing? That's the first question. The second one is the dementia charter. If I remember, last time I was asking the question, who is signing it? And I think it was predominantly statutory organizations. However, we do know that the support is provided by a myriad of different organizations. Is there a plan to engage all the providers in signing the charter, but also do their self-assessment? So it's not just about signing a charter, but it's about actually looking how well we're doing what we are doing. Is there a plan to extend outside the statutory body, please?
There is. I spoke to our contracts team, so it's something that we would ask the other organisations to take on a voluntary basis, so so it won't hold up the contract signing process. But yes, it will be sent around to other organisations to sign, and obviously get endorsed as part of the actual package. In terms of our biggest challenges, I think it's just really in terms of getting our information together, identifying patients at risk, and doing something earlier about those patients. We will be working with population health management as well, to try and our primary care teams to get the patients identified, and then we can actually work on what the resources are that we need to take that next step.
Thank you. Kathy.
Hi, I'm Kathy Armour. I'm a non-executive member of the ICB. I was just struck by the charter and people signing the charter and signing up to do, you know, the things that they're doing. But the experience that Liz had with people in, you know, social services, the council, etc. It's so, you know, I'm just envisioning them signing up to a charter and then not very much changes, because it takes time to really kind of move on this stuff, doesn't it? Embed it and share it. And I just wondered what your thoughts were about the time frame and how quick to mobilise once people have signed up, which is the first step.
That's a very good point, actually, Kathy, because as you say, they can sign it and then they can forget about it. But I think as part of our work stream, we do actually need to make sure that we can get things going as quickly as possible, and that it's a regular review and it's not just one signature and that's it. We need to keep the focus on it and make sure that it's delivered as quickly as possible.
What's your thought about time frame?
Well, we are working towards the end of March, so we do want to get this all the gap analysis done by then. So we want to try and move this along as quickly as possible.
Okay, all right, thank you.
Thank you, Frankie.
Yeah, I think Kathy, you put it very well. The dementia workstream that was part of the Mental Health Collaborative, it had two aims. It was to set up a charter, get people to sign up to it, and to set up some training for staff. And those things have happened. But does that mean anything has actually changed? No. Yeah, that was just some preliminary work that had to be done. Now the real work starts, because as I mentioned earlier, there is no actual pathway at the moment. When we've spoken to people, and Liz gave a beautiful example. Actually, there is no guidebook. There is no what to expect, what happens next, who do I speak to, who's my key worker, which we've heard loud and clear from carers and people living with dementia. What they want is information and somewhere to go for support. The medical aspects of this are a drop in the ocean. It's much broader than that, and so that's the real work that is starting now, and we cannot do it alone. Really, really important that VCSE, VCSE sector is generally the first place people go to for help, and then they go to their councils, and then it's the NHS. But we happen to be the conveners, so that's absolutely vital.
Okay, thank you, Frankie.
Thank you, Frankie. I can't see any more hands up, so I am going to. Janice, thank you very much, and thank you to the team in the background. I'm going to go to Heather now. Place-based dementia focus. Heather, can you take us through that in a very swift way, please? Just overrun.
Well aware of the timescale, so yeah, I'll do my best. And can you see the slides? Don't panic at me putting slides up. I'll get through them pretty quickly. So again, I just wanted to mention Emma Bohr's work. I can see that was mentioned in the chat, but actually anything I'm presenting today is all down to a member of the North team called Emma, who's now transferred to the Children and Young People team. And also Liz has been heavily involved in the work of the group. So just on bear with me, numbers, what particularly struck me here was that it's an incredibly frightening environment to be. And yet people with dementia in hospital twice as long if they're over age 65 than other people, and that 43% of them go in with things like urinary tract infections and chest infections, which are perfectly treatable in the community. So not only are they going in, but they're going in inappropriately, and that must be a terribly frightening environment. So we've got this North Norfolk Dementia Working Group. It was set up as part of the North Board structure, but it's also got really strong links into the North Partnership as well. I think we've spent a total of about 2,000, and that was on postage, is the only money this group has had for what it's achieved. And it was very much around this identifying, mapping, promoting them and maximising what's already out there, not trying to come up with new things that are going to cost more money. Really mixed membership of people that are working in the space, but also representatives from local groups in North Norfolk, people living with dementia and their carers. So the voices were a really mixed group in there. And then achievements to date, and the two documents that are referenced in here, I've popped over to Rachel so she can send them out afterwards. But so I particularly want to mention the leaflet, which was very much around pulling together the information of all of the things that were already out there, because the group started with an assumption that there were lots of gaps. And actually what they found was there was just really poor communication, and those things hadn't been shared with people and communicated to people. So they produced that. They also produced the dementia infographic, which is a really lovely kind of 2-pager, which talks the individual through talking to their GP, receiving a diagnosis, and what they can expect then as the next stages around their health and well-being, their home, their friends and family, and their future plans. So those are the two particular documents that are important. The other thing that was really simple was that due to a change in the form, we'd ended up with a position where NSFT and Alzheimer's had to have 2 separate referrals from a GP, and all it needed was a tick box reinstating. And so it was something that was identified as part of the work of the group and got back on. I can see a knowing smile from Frankie. And you sort of the silly things that make a huge difference for everybody, actually. So as I say, we just on the numbers down the bottom, we've got 14 GP practices who've worked with us on the Protect Now proactive dementia support calls. There were 1,056 eligible patients, and there were 422 requests for support from social prescribers or as in support to be given by social prescribers or wider partners. So when you think about all of those calls that Protect Now made for all of those individuals and the conversion of the amount of people that needed help, it kind of reinforces what Liz has just told us, which is how much help is needed out there. So looking forward, this is the group came to us as a board and said, this is what we want next. So we've done this and this is now what we want. Very much around now promoting those documents that they've produced, getting a local charter that's signed up for in North Norfolk, and also we're trying to get the group, keep the group going, because with Emma disappearing, these groups are as much about the personalities and the commitment of individuals and personalities as they are about the groups themselves. And so making sure that we've got that leadership to carry that group forward. And that's been picked up by Simon Bohr, who's our integrated director for NCC and NCH&C, and he is now looking after the group as a holding position, and they're going to have the Protect Now data presented back to them at the next meeting so that they can hear what happened as a result of that. So there's some really good plans looking forward as well, which is positive. A couple of comments here. And I'll particularly pull out, which would ring with what Liz said. We are at crunch point, carers are bewildered, and that carers want proactive, not reactive support. And I think those were the 3 that really struck me on the members' comments. And so in terms of feedback to the wider system, those living with dementia need is not complicated, it's the system that makes it complicated. And basically, much like Frankie was saying, let's just get the fundamentals in place. It's, we all know what needs doing, we just need to get it in place. And so just some final thoughts from the group. The importance of the support and experience provided by loved ones and the community should never be underestimated or undervalued. So as I say, we're just trying to get the group back up and running. We did have to pause it for a little while, but it's a fantastic group, and Liz is a very active person around that table, and we're very grateful to have her. Hope that was quick enough.
Thank you, Heather. You can breathe now. Informally, Heather, I've been receiving very good feedback about it. People are mentioning it without solicitation, if you see what I mean. So please, can you say from us, thank you to everyone involved in the group, but also what you have demonstrated, and for the work they do, but what you've demonstrated, that if you get the right people, the right brains in the room, and communicate the right way, you don't need lots of money to make a shift in the quality of what's available and how people access it. So well done for doing that, and Place clearly has a place to make that happen. Very good examples, and I wish you all the best going forwards with the work. You're saying you need to sort of reinvigorate the group. Please do so, because we do want to see those changes for our people. And those who care for them. So Heather, thank you so much. I was waiting to see any hands up. At the moment I can't, but you know what, we'll look forward in a few months' time to get another update at the same time as we see updates from dementia workstream when something actually started to happen, and see how they go parallel and the impact they have on our local community. So Heather, thank you again. Thank you indeed. Okay, royally late. But never mind. Place board report from South Norfolk. Olga, I think I met Olga.
Yes, hello.
Oh, I did. Olga, welcome. I've attended the South Norfolk Place board meeting. It was my last one to attend out of 5. Very good experience indeed. And Reading your report very much reflected the conversations, and I must admit, what a good report. So without any further introduction, you can introduce who you are exactly. Please, can you update us on the work of the South Norfolk Place?
Yeah, good afternoon, everyone. My name is Olga Tsirogianni. I'm the acting associate director of PCN development for South Norfolk for the ICB. Apologies for the long title. I have read, I have written a report and a presentation, so I think conscious about the time, do you want us to do more questions or do you want me to draw in some main points? So it's up to you, Aliona.
Yes, please, just draw some main points and then we can open for questions, please,
yeah.
Olga.
So our report came as a reflection of the 2 years. It has been 2 years since we have established the place boards and the health and wellbeing partnership. So I thought it's a good point to actually reflect a little bit on the work, what we have learned and where we're going next. And it's very nice because I think you don't realize how many things we have done. So we have listed some of the projects. I'm not going to go more into that. But I think for us, it's about what has changed. So I think that was one of the questions, what has changed on the ground? And I think what we have found is that our relationships and how we solve problems have changed by creating more contact points, by working together on different projects. We can see that our relationships across the local system have changed. People will just pick up the phone. I remember there was a time when we will get an email from the CEO of the Breckland Council and we'll go down the lines from all the directors, prepare a formal reply. And now it's just a phone call or a simple email. And it's not a big deal because it's things that we're discussing and we're solving all together. Also recently in the community services review, the South Norfolk GPs were the only ones to give some positive feedback for the community teams in NCH&C. And I think that's not by accident. We have worked over the last 3 years to improve our services and increase the collaboration between NCH&C and primary care, and that was then showed in the results. So I think the ones that they have engaged, because not everybody has engaged fully in this process, I think they have seen the impact. And also we have always tried to, I see my role as trying to help whoever needs us, because whenever there is a problem in the system, that has an impact on everyone. So another example, our community mental health team found themselves at some point with 2 out of 10 people. Well, that has an impact on our GP practices. It has an impact in A&E. So what we facilitated is for our social prescribers to review some of the easier cases together with clinical people from NSFT and try to facilitate, a redirection of these patients together with primary care. Again, we helped all together, and that means that now they're in a much better, more resilient position, fully staffed. So I think it's a little bit that's what has changed. But when we asked, when we asked what brought you around the table, it was the promise that we can solve complex issues all together. They told us that it was about being part of the developments. So they wanted to influence what's happening in the system and find better solutions for our patients. But then we discussed, okay, where are we now and what we would like to do next? And there was a great enthusiasm because the last 2 years we have learned how to work together. We have experimented with new ways of working. And we found also what's difficult. For example, you probably have heard it already, IG and data sharing. It takes us around 3 to 4 months at least to do anything in the system. Another example, when we did social prescribing for secondary care, our colleagues in the acute wouldn't refer to a .gov.uk email address. And even when we showed them in the website, they were saying that it's safe, they wouldn't believe us. And they had to go up the line to the IG people to tell them that's okay, and then come down and say it's okay to start it. I know it sounds funny, but that's project management resource and time, which sometimes it means we lose time-sensitive information. So I think it's a great point to reflect on enablers and blockers and how we can solve them for everyone. The other thing, though, that people said is that they want to do more. And I think that's fantastic. So now that we have experimented with all these integrated ways, how we can support the big strategic aims of the ICS in a coordinated way. So if it's respiratory, if it's CVD, how we can all work towards that and align our efforts from the primary care, community services, what we're doing with the VCSE, what's happening with the district councils. So the impact is visible, because I think what has been happening for the last 2 years, place boards have a lot of priorities, mainly based on the population health management for the place. But it means that it's very difficult for the system to feel the impact, because it's happening in different things. So we might be doing something with mental health, somebody else might be doing something with CVD, someone else is doing something with respiratory. And that's then very difficult for the acute to actually release capacity, funding, or space, because they cannot feel the impact. So I think now we're in that critical point where we can actually undertake bigger projects and work in a very streamlined way across the system to deliver that impact that we need. Other points, of course, you probably know, there is a symmetry in power dynamics. Sometimes big partners, small partners, we have restructures that makes it difficult sometimes for them to attend. Even for our teams through the restructure, it was hard to always support all this work in a consistent way. I think a lot of these things are finishing, so we will be in a better place. And from us, the ask as a place board is that, one, we want to take bigger challenges. And the other thing is that we would like place to be represented in more areas, because we bring a unique view of how we can help and facilitate and deploy different solutions, which sometimes is not obvious from somebody who's a little bit removed. So our engagement in more of the strategic work, systems and programs, we believe can help the system.
Well, thank you. It's interesting you picked up on power dynamics. I was the slide in front of me, because what was going through my mind when various presentations are happening is how we actually engage in the smaller groups. Janice was mentioning earlier, voluntary sector is quite important in the work, dementia work. There's so many areas where small voluntary sector organizations who have a footprint in certain areas can do lots of intensive work with people and make a difference, whereby a statutory body having one employed member of staff doing coordination of something may not have any of that impact as a result of their work. So let's not recreate something, but let's look at exactly what assets we have, what expertise we have, and engage those people into planning and deliver it to measure that impact and to have the impact sooner. So one thing I didn't get the feel from in the South Norfolk place is how much the voluntary sector organizations are involved in the place working, and if they are not, what plans you have in place to make sure that they're integrated closer within the place working in your area. That would be one of my questions, please.
Yeah, so I think we need to be seeing place board always in conjunction with the health and wellbeing partnerships, because it's one and the same in my mind. We have almost all the members are the same, but they have slightly different membership and slightly different focus. So in the health and wellbeing partnership, we have loads of our VCSE partners. We have funded a lot of projects both in Breckland and in South Norfolk. And this is where we're mainly looking prevention and how we connect with the communities more. Instead, if you're looking in the place board, we're looking a little more the statutory services and whether they're working well. So some examples in South Norfolk, I was in the Overview and Scrutiny Commission the previous week, and we had the DAISY project there, we had the police, we had Citizen Advice, we have Amy Griffiths. So a lot of work happening, but that's the place where, because I'm attending both, the district councils are attending both, our NCHNC partners attending both, whatever we see that's suitable for that forum, we move it there, and that's where we engage further with both the communities and with the VCSE.
Can I share a secret with you, which is not a secret really, but all the partnerships are engaging the VCSE sector in a very different way. And many times the VCSE providers are sitting there with their own hat on, not the sector on. So they don't really communicate to anybody because they're there to think about their organization. So my plea will be, and I don't see why the VCSE should not have a connection to the place per se in their own right, through the assembly. and that is coming in a minute on the agenda. So my plea will be, can we just rethink those assumptions, because it's not quite the way you are describing, and I think we need to make sure that there is more uniformity across our places and across our system, just to make sure people understand how it works, because it isn't at the moment very clear and it's all very different. So I'll come to Mark Burgess and then Mark Hitchcock, please.
I'm just going to say, if it's related to that, Mark, did you want to go first? Then I'll come in with a separate point, if that's okay, Leona.
Please, yep.
Thank you, Mark. Yeah, I think I've got a set of steak knives because I belong to all the health and wellbeing partnerships. And in absolutely none of them am I a representative of the VCSE sector, because there's 11,000 people I don't get to see every week. So I would echo that. And something I've said to South Norfolk and Broadland and also to West Norfolk is we need to stop talking about cash for short-term projects. If you take money off the table and see who turns up, then it makes a different dynamic. So that was our feedback on the last piece of funding that came through, because it's too short-term and sustainable in terms of the way that VCSE operates. So I'd echo your concerns, Eliana. But it's not just a South Norfolk Broadland concern or South or a place board.
Thank you, Mark. I only go to Great Yarmouth one, so I can only comment on one. Even that one, I missed many because it's clash of dates. But nonetheless, that is the feedback I'm getting, and it's very important that at the system level we recognize that and we do something about to put it right. Mark, may I come back to you, please?
Yes, thank you. Thanks, Eliana. Thanks, Mark. Olga, thanks again for the report. I'm really struck by the point on one of your last slides, which around place partners are eager to be tasked with addressing bigger, impactful challenges, and I think that's a kind of common theme that we see in all our places, which is really good. And for me, it's actually about how do we really harness the power of place and partnerships and relationships to help deliver those system objectives, because I think that is so powerful. And I've been around with Aliona and separately to many of those place boards, and actually seeing some of that transformation that's happening at a local level, so the local focus as well as the kind of system focus, and getting that balance right is really important. The other bit that I'll share, and I've heard this from South Norfolk and all areas, we know, working across health and care and in the voluntary sector and many others that we touch day to day, our teams are struggling, and that it's really hard work. But almost without exception, when the people are working this way at place, those relationships are good and are strong. Feedback from teams is they feel valued, they feel they're achieving things, and they're generally very, very positive about it. I don't think we should underplay that, because actually when you get people who are in that headspace, you tend to achieve far more. So that just a quick but I think important point. So thanks, Olga.
Thank you, Mark. Thank you. Tricia, and then I'll bring to a close.
I didn't introduce myself earlier on, Aliona, so I'm Tricia and I'm the Executive Director of Nursing for the ICB. I love place. I love the potential of place. And I do think that with the fiscal position we find ourselves in, health, social care, with finite resources, I think the great potential of place is the conversation that can be had about the outcomes needed for a geography, and how the collective power of all of the experience of a variety of people, providers, organisations can come together to deliver those outcomes. That's where I think we see the greatest innovation. And we've heard from Liz earlier, by doing the same, we get the same outcome, which isn't where we want to be. So I think as places mature, I think there is great potential for doing something very different to support the local population.
Indeed. Thank you, Tricia. Olga.
Eliana, if you indulge me for a couple of minutes, just to add to what Patricia just said. For example, in Wharton, in Breckland, we commission a model of community health and wellbeing workers. So these are Band 2 people that they're employed by the district council, but they're fully integrated in primary care. So they work in the most deprived communities, and they knock the door of these households, around 100 to 150 each, every month. And what we have seen is they start usually with their social needs, food vouchers, problems with the housing, but then we start discussing about health. And then what they started doing, they booked them for NHS health checks. They increased the vaccination for adults and children. They stopped calling in the practice during the day. One of these people, they led them upstairs and he was ready to hang themselves. We found cases of modern slavery. But not only it's so fantastic, if you ask our GP partners there, they will tell you they had the best cough year than they ever had in their hardest year, because they had lost 3 out of the 4 partners. And this goes back to what Tricia was saying, that when we work together in an unusual ways, nobody would think, a GP practice and a district council could have such an impact. We see impact on things that we're trying on every day to reduce emergency admission, any attendances, demand to primary care. So I absolutely believe that place is the place that we can use to achieve a lot of our aims.
We don't disagree with that. And from your report, it's very clear that there's lots of good stuff happening. And I listened in the meeting when I attended your meeting too. So it's all very encouraging. Yes, the main message from us today, or from me in any case, is please do remember that there is another sector who needs to be party to the thinking.
Can I just say, because I forgot to say obviously, that we did speak with Daniel Williams, who is the representative for the Assembly. So it's just that if you ask me personally, really, where there is a lot of work, it's not that we're not linking, and we do have, I know they're not going to like that if I say that in the VCSC, but in both of our partnerships, we do have some of the infrastructure organizations, and we have organized many times events with them. So
now, Olga, it is work in progress for everyone, I am sure. And we're going to hear in a minute on the update of the VCSC Assembly, because that is going through a refresh too. So as somebody said earlier, the restructuring of the ICB is coming to an end. We know where we are heading. So now is the time to get everyone, the right people in the right room, to have the right conversations. And I think that's all positive. From us to the South Norfolk Place Board, big thank you. And I'm sure we'll visit you soon again to offer support and take it to the next stage.
Thank you very much.
Thank you, Olga. Shirley, may I come to you, please? I'm sure she was there.
I am. I'm here. I'm here.
Good. Okay, I can't see you on the screen, but as long as I can hear your voice. Shirley, you have shared with us, or Emma shared with us, the minutes of the last VC Assembly meeting. Please, would you give us some highlights of where we are at and where we're heading, but very quickly, if at all possible, please?
I'm just going to invite Mark, because I just want to make sure, because Mark is officially Emma's deputy for today. Just invite, I don't know, Mark, if I'm happy to cover it if she hasn't set you up with some points in terms of summaries, but I thought I'd invite you to go first.
Just didn't know who is doing what, so.
Yeah, no worries.
Between you two.
Very kind of you to dump that one on me, Shelley, but thank you very much. I'm not going to read the paper to you either. I think the key thing is that there's a clearer structure coming through. There's a number of people taking on portfolio roles. I think the last meeting was most important because Shelley and Mark were there just explaining what's going on from the ICB side from Shelley's new role, but delighted she's got, and the team that she's putting together. So coming back to your point, Aliona, I think the pieces are starting to come together. I think the challenge to do something then, rather than worry about the governance, is the key thing.
Indeed. Shirley,
you
are in your new role. Very quickly, please.
Yeah, so new role. So we have a head of health inequalities and voluntary sector partnering team in the ICB. We came into formation on the 1st of July, and we've been migrating the team members over from the different parts of the ICB as part of the restructuring process. But we are now to full capacity and have been for 2 weeks. We are recruiting for a new VCSC Assembly chair. The interviews are on Thursday. Because Emma Ratzer has served her term now as chair, so the initial appointment has concluded. So we've got that happening at the moment. And I think colleagues will be aware we have brought a paper previously that we've been going through a bit of a review and refresh of the model and thinking about that kind of portfolio holder approach. So that it's a really, really clear and transparent kind of set of representatives from the sector who are representing around different joint forward plan priorities, but also wider priorities that we've identified with the sector are important. So as an example, we have recognised that we have a gap around communications for the Assembly. People don't understand what it is. It's not necessarily, we're not necessarily thinking through that link to places, as you've talked about previously. So We're going to recruit a remunerated comms lead position within the Assembly as part of the Assembly model, someone to help us think about that comms strategy and how we engage the wider sector alongside that new chair appointment, which I think will be massively helpful and help to address some of the issues that we've been thinking through for the last couple of years. So we're drafting up a new terms of reference for the board. Obviously, we want to do those appointments of those vacancies with the new chair position. Emma was quite keen that we do that with the new chair, so we'll be doing that as soon as that new chair is in position, but the appointment is due to be from the 1st of October, so we are going to be moving quite quickly, and we have been talking about how we implement a request process with the Assembly Board for representation on governance structures, so that there is an actual process and a conversation about who is representing where, and how that communication then flows back to the sector and into the ICS governance structures. So once we have a clear process, we will be able to bring that out and start to really communicate it alongside who the portfolio holders are and what they are responsible for doing, how much time they have, etc., etc. But we're just waiting for that last step of that new appointment process, and then we'll be good to start really communicating, I think.
Excellent. Yeah, progress made since the last update, so well done and thank you. Good luck with the recruitment. We do hope to get the right person in place as for the 1st of October. And most importantly, it will be good now to start having discussion about how the VCSE Assembly makes an impact and a difference and how it engages and all that stuff. So the stuff we wanted to have a discussion last year, but again, better later than never. Sometimes we have to learn from what we do. Is all about learning process, is about reviewing and doing the best we can going forward to meet the need of what we want to achieve. So that reiteration happened now, and yeah, I cannot see any hands up from any of the committee members. Oh no, I can see one now, Tracy. But overall from us, well done to getting us where we are, and let's hope we make now the proper operational progress with it. Tracy.
Yeah, just say I'm really pleased about the kind of the refresh and the roadmap forwards with the Voluntary Sector Assembly. I think it's really positive. Really pleased that we've got that join up with the Health Inequalities and the voluntary sector partner. I think that's going to be key. We know our voluntary sector is just essential partners in our system. They've got the closest contact to our communities. And I think if we're going to address health inequalities, we cannot do that without working really closely with our voluntary sector and our districts. I think equally important is that with the Health Inequality Strategic Framework, one of our key pillars is the living and working conditions, and key in that is going to be how we work, how we support our voluntary sector and embed the work of the voluntary sector in all that we're doing. So I'm really, really pleased about this. Just something I was thinking about, Shelley, and I don't know if we've kind of spoke anymore, but I know that we've learned a lot from the work that Frankie's done with the Clinical Care and Professional Assembly, and I know we talked about some kind of learning and sharing with the Assembly work going forwards, and how clinical and care professionals are embedded in all of the kind of work of the ICB, but the ICS more widely. So that'd be really good to get involved and do some of that.
Thanks, Tracy. Just to mention, I did go out to the CCP, was at the last meeting, Frankie, I think it was. So I went and did a presentation on the sort of progress around the Assembly, and we started to have that conversation about the link up, because I absolutely recognise there's learning there and a need to connect. And Frankie and I spoke about the chair perhaps having a position there once we've got that appointment in, just to maintain that connection and make sure that learning's feeding in.
Excellent. All very good. All sounds very good. So thank you so much. I'll move on the meeting, but well done, and good luck with the recruitment in the next stage, Shirley. Shirley, thank you. Thank you, Mark, for stepping in for Emma. Andy, I'm going to come to you now. Housewife Suffolk annual report, please.
And take a breath, Aliona. So back in July, both Healthwatch were invited to talk about their annual reports, and Alex did so. And on this occasion, I'm going to invite Michael, who's our Communications, Information and Research Manager. Thank you.
Thank you.
Thanks, Andy. Thanks, Aliona. Good afternoon, everyone. Aliona, I'll be guided by you here. So there's a presentation that I created. Probably take me about 6-7 minutes, possibly less, to go through that, or I can just direct everyone to a web link and I can talk you through kind of the approach we took this year. Entirely up to you.
We had seen the full report, 65 pages or something like that. I did read it. Lots of interesting work you've been involved in a very meaty report. Well done indeed. can I suggest that you give us the highlights of the things which really stood out for you, the ones we really need to pick up as a system from it, please?
Yeah, tricky. It's a tricky ask to kind of give the highlights of a year of local health watch work. I think what I'll do, if I share a link to the report in the chat, what you'll see is first we sort of describe some of the kind of numbers of things we achieved. What I would say is that we've just had a look at the total kind of amount of insight that we've gathered since Healthwatch began, and I reckon we've processed somewhere in the region of between 155,000 and 200,000 items of individual research responses and comments, which is a huge amount of qualitative data, I can assure you. And in the last year or so, that kind of amounted to around about sort of 25,000 across our research projects, etc. We have an online feedback centre, which is essentially like a review platform where people can find and review their local services. We have 23,000 individual comments listed on that site across hundreds of services now, and all of those comments get fed into our work, either to respond to the media, to share insight with Healthwatch England or local committees, all sorts of uses for that data on top of the insights that we gather through research. Now, I've highlighted kind of 5 ways that we aim to work as a local health watch, and that's by engaging people in services, and that enables GP practices to make changes to how they deliver their services, etc. And we've got examples of that you can find on that page. We do research, as I described, as Susan described one of our projects earlier, but we published 20 reports last year, around children and young people's asthma, smoking. We're working on projects around virtual wards and family carers. We're working on a project right now around spinal services. We do a really big project called My Health Our Future, which some people might be aware of. 66,000 responses from children or from young people across the lifespan of that project. And we know that those insights are used across sectors to achieve impact and change for young people, particularly in schools and colleges, etc. Now, what I would say is that this year we sort of tried to explore our impact in a slightly different way. You will find something like 6 different types of impact that we achieved in our year last year. So just to quickly mention some of those, we talk about strategic change. So the dementia project was a really good example of that. We know that the key learning from that project was threaded throughout the Suffolk Dementia co-produced Suffolk Dementia strategy. The key learning was also embedded into the service specification for a new pre and post diagnostic dementia service locally. CQC picked up the learning from that research and said that it would use that key learning to inform its national approach to dementia care, which could have a really big impact, not just in our locality, but actually nationally as to how CQC goes about that. But you'll find other strategic changes around maternity services and all sorts listed there. We also talk about changing services, like the changes GP practices made. We talk about personal change and signposting. That's about the impact for people engaged in our work. So people that we've signposted and helped to navigate and find their way through services. More than 1,000 people signposted last year by our teams and communities and by calling us up, etc. Then there's cultural change by encouraging services to work in co-production. Again, lots of examples from our co-production team about how we did that last year. And then also, obviously, the impact and influence that comes from sharing insight with committees like this, with the Health Scrutiny Committee, Health Wellbeing Boards, countless forums across health and social care that I'm sure many people are involved in, but that we know has a wider influence on ultimately the kind of support that people get. And finally, the national influence that comes from our work with Healthwatch England. We contribute insight to government committees, calls for evidence, all sorts of things, all sorts of ways that we share our kind of insights and our intelligence, ultimately to improve health and social care support for local people. That's the end goal of every single one of our projects. And I'm pleased to kind of report really that we've been able to identify so many impacts, and that comes from working with kind of true system advocates. You know, people, the most impactful work that we achieve comes from having people that we work closely with within systems who take those insights and drive that change, because ultimately change is done by organizations, but it's about the people in them. And so if we foster those good relationships with commissioners, people working across health and social care, the span of work is ridiculous. You know, the span of people we need to work with and influence. But ultimately, I think my kind of key takeaway here is that what we look for is for people to kind of look for our insights, take those on board, and be a real advocate for kind of people's lived experience in driving that change. That's where I'll leave it. I'll let Andy come in with any sort of final summary thoughts. I'm really sorry, that was a really, really quick overview. Please do have a look at the website, have a look at those different types of impact. If anyone has any questions about them, any of our work, any of the research we've completed, just get in touch and I'll be happy to help.
Thank you, Michael. Thank you. Andy.
I'm not going to add much to Michael. The only thing I would say is that if at any time you're wondering if there is anything in our toolbox, so to speak, Michael has created and will keep updated an A to Z of reports online. So you can do a search and then you may find a subject area that's of interest to you, or it will help you in your work at any one time.
Thank you. As I mentioned earlier, yeah, it's quite a lot of work you've been doing, having read the report, impressive portfolio of work. Now, the question I have is of reassurance as such. Now that the ICB structure is settling, do you know what the channels are to communicate any findings from any of your reports to the right people, so you don't go around the houses, so you can get the message to the right?
No, we knock on doors each time, Aliona.
So what can the ICB do to help Healthwatch now? Where to go, please?
I think just if there's anyone that particularly would like to receive our insights, where it would be helpful, if there are any spaces where people's lived experiences are considered, I'm very, very happy to take note of those and share information proactively. What I didn't mention was that in the coming weeks, we will be launching quite a major piece of research, which will be focused on people's lived experience of waiting for hospital care, elective care delays. Now, that is a piece of work that we are working very closely with James Paget Hospital on. Really pleased that they are fully engaged in this work. They've been co-producing the survey with us. They'll be helping us to reach patients. So the insights from that work will certainly be shared within the coming months. And so obviously we'll be looking for not just a response from the hospital, because waiting for elective care is not necessarily just a hospital issue. We know that it's about making sure people feel supported whilst they're waiting, and very often people haven't. So it's really about a system response. So if there are any thoughts about people we need to include in that work going forward, don't hesitate to get in touch. And in terms of the general insights, anybody that wants to receive those insights from us, sign up for our MailChimp or let me know, get in touch personally. I have a list of people that we share our reports with when we publish them. Point me in that direction and I will make sure that they reach those individuals.
Thank you, Michael. Thank you, Andy. Mark, very quickly.
Very, very quickly.
One
just
of
to
those people.
Yeah, so just to say, but please keep knocking on doors, always helpful. But equally, both in this forum and outside, do link with myself, Rachel and the team. If there are things come up that you think can't wait, then let us know and we'll be absolutely happy to link to the appropriate area if it's not us ourselves. So please do use us that way. Thanks.
Excellent. No, thank you so much. Thank you again, and well done indeed. And congratulations to your team, Andy, for doing all that work. Thank you. Okay, I'm going to move on to Alex now. Alex.
Hi, we were asked to just concentrate on a couple of hot topics, so I chose the. Can you hear me?
Yeah.
Yeah, so I chose the 2 SEND events we went to and the 2 Pride events that we went to. I'm going to start with the SEND events because I think what really those bits of information I'm taking it as read highlight are sort of health inequalities not just creeping in, but running in at a rather rapid rate. For example, those who can afford to pay can use private consultation, but this still leaves a huge barrier for those unable to pay. And that said, even those who are recipients of diagnosis, there's little or no treatment available for their charges. And this isn't necessarily due to lack of financial resources, but an acute lack of appropriately trained staff within the system. I think, so that's my sort of big take on the SEND stuff. And the fact that diagnosis is now, 10 years on, taking up to 4 years to receive a diagnosis or an appointment. And if you're a young person, 4 years is an incredibly long period of time. As we grow older, time obviously goes a lot quicker, so we don't notice it. But it is what it is. I think the Pride report is quite interesting. I think I have to be very guarded how I word this, because I think some of the stuff that people were responding to us was a little bit wokish. That said, I do think that people have come up with several good points. So we were having transgender female to male who were not being offered various tests that should be offered, and it was also not necessarily being explained to lesbians that why they might need a pregnancy test. GP practices don't always know whether somebody's sexuality unless they're very explicit. So somehow we need to get our way around that. The use of personal pronouns was another thing that's come up. Again, I have a very personal view on that, which is probably somewhat contrary to those that responded to the survey. I think that the other thing, you're having transsexual male to female who weren't being given prostate tests, because our understanding is that the prostate is not removed during the operation. So that can have an impact at a later date as well. So I think there are just various issues that aren't particularly difficult to address, but require addressing.
Alex, thank you. The latter one, I found it very interesting reading. Personal reason, I do have a transgender child, so I went through all the process myself and understanding it, and goodness me, what an education I had to have and awareness raising to understand all that. So for me, lots of it is about actually how do we improve the understanding of our health professionals and in social care or anyone frankly supporting people in whatever capacity about what those things actually mean. Because we're all guessing and we make assumptions, but there's lots of learning. And your recommendation at the end, where maybe extending this to more sort of in-depth report, is very good one. And I do hope that the local project, Norfolk LGBT project, will find a way of working with you, because there's lots of things we can learn and make better in that area of work. But that will be from me. I'm sure Tricia now.
I can just reply to that. We work very closely with the Norfolk LGBT group, so and we are carrying on the work.
Good, thank you. I will look forward to when you publish the next one, hopefully more in-depth report, to just see what findings you have there. Thank you, Alex. Tricia, and then I see another hand and I can't see it now.
Yeah. I'll be brief. Both of the reports actually made for very stark reading. So, but can I start with SEND, Alex? From the perspective of both our local authorities and both our ICBs in Norfolk and Waveney and in SNE, we are working to deliver an action plan to address the many gaps that we have in service provision for children in the SEND domain. There is much more work that we need to do to actually support parents in advance of the diagnosis, because that's often the support that they require is around some of the presentations from their child. And while they're awaiting a diagnosis, there's much that can be done to support those families better. So there are two plans in play. Are they delivering quickly enough? Probably not. But there is an appetite and a commitment from the local authorities and the ICB to make those differences happen. Interestingly, you focused on a dearth of healthcare professionals, and it is very, very key in this area when you think about psychologists and speech and language therapists. So that is recognised, but I'd welcome a conversation with you outside on that one. And then on the next one, which was the feedback from the Pride, I think that this isn't about bias. Having worked as a practice nurse for 20 years, practice nurse at an ANP, it's often not having the information and not understanding well enough. So I was talking to my lead colleagues who work in primary care, and we've started talking about having a practice nurse conference to reinvigorate our relationships with our practice nurse colleagues. And in a very timely way, we wanted to think about those very transgender issues that you're raising in your report and how we make it easier for healthcare professionals to have the right conversation with their patients, because that's what you should be endeavouring to do. So again, Alex, I'd be quite keen, if you've got such strong relationships with the LGBTQ plus group, the strength of Health Watch, I think we could do something quite spectacular to actually raise awareness. So again, I'd like to have a further chat with you about that.
And, no problem at all, Trisha. And as you know, well, as most people on this call know, Health Watch Norfolk paints a fair few gay people within its organisation.
There's plenty of lived experience around us, I'm sure we can draw from too. But of course, it's important that we open the net wider to get wider perspective. But Trisha, thanks so much for your questions. Before I come to Tracy, a couple of things. Rachel, there is some links in the chat box, if we can just put them into the minutes. But the important one, Frankie, you just expressed your conflict of interest related to transgender work. Well, I also have to express that just because of personal relationship with transgender young adult. So, but I'm not connected to the LGBT project or anybody else or to Frankie's work. So I think I want to make that clear that I'm not involved in anything. It's just personal experience. So again, we need to register those properly, please, Rachel. Okay, Tracy.
Yeah, I'll be really quick. So just going back to your Pride report, Alex, I know we had a really good conversation when I came over to see you recently about that. So I think there's an opportunities in respect of all of our communities with protected characteristics and those with health inequalities in respect of our equality health impact assessments and some kind of wider system work we can do in respect of that. So really keen, certainly from our health inequalities perspective, we take that work forwards. And then also we're doing a bit of work at the moment with our primary care workforce team around some health inequalities training for primary care for all of our primary care staff, and I think that would include those elements of some of those protected characteristics as well as those other elements of health inequality. So I hope that will be positive in supporting staff in the primary care sector as well.
Thank you.
Thank you all. Alex, thank you to you and to your team for undertaking the work, and yeah, let's use the findings in our forward planning. Thanks so much, Alex. Frankie, I'm looking at you. I'll see you on the screen in a minute. You usually save me from the fact that I overrun. So we're going to go to Population Health Inequalities Board update. The report has been circulated as always. Frankie, please, can you just highlight the main things you would like us to be cited on? And I can see there's some items for escalation, and I think you need our support on something. So over to you, Frankie.
Of course. So briefly, you have the report, but the edited highlights are that the procurement of the PHM software has now completed. So we're expecting to make announcements very shortly, subject to contracting. We have a particular PHM project that I'd like the committee to be aware of, which is proactively contacting people who have been offered a health check. This is the 5-yearly health check for everybody over 40. People who've been invited but haven't attended, it was so successful, we actually had to pause it on the second day because we completely overwhelmed the provider because we booked in 277 bookings in one day. So that's how powerful our PHM process can be. But it's one of the most important things we can do. It's a way of going out and finding people with hypertension, for example, who don't know they've got it. That is prevention in action. The third thing I wanted to highlight is we've done an evaluation of one of our big projects that we did last year to really demonstrate the learning. And the learning is pretty stark, that we can identify people at risk, we can make successful interventions, but even if we incentivize primary care to take the action, they just don't have the capacity. So we cannot assume that handing the data over and handing over the list, these are all the patients that you need to contact, it's very easy, this is all you have to do. They are just terribly busy with the day job. So we really have to bear that in mind in our design of any future projects, which we have, and so which is why we'll often do central provision of the intervention, even though we'd like to do it more out in the community. And as Olga was saying earlier, it's our places who really want to deliver this, but sometimes they just don't have the capacity. The next thing I wanted to highlight is our equality, health and impact assessments. Alive. So this is really, really wonderful news. No longer is it up to somebody to mark their own homework and say, oh, I don't think this is really going to impact anybody. We now have a discrete panel so we can have uniformity, some objectivity, and it has built into that process. Have you considered our Norfolk and Waveney Plus groups explicitly to really strengthen that? So I think that's wonderful. Only two more, nearly done. The next was
Frankie, on that one, can I ask you? So when those reports come to the panel you just described, and you ask the question, and they say, "I did, but not fully," what happens then?
I will hand over to Tracy Williams to answer that question, if I may.
Yeah, I think it's quite a complex template in many ways, but it's very user friendly, but it prompts you to take actions, whether they are negative or positive actions, and to make adjustments where you can. Sometimes it's challenging, but there are kind of prompts and actions, and what you can do, what you need to do. And as a panel, if you haven't done those things, then we will very much, as part of the panel, pick people up on it. Exactly.
Yeah. Okay. Good. Thank you.
The next item was a proposal for the Wellness on Wheels bus, which grew out of the vaccination programme, does wonderful work getting vaccinations out there. And our Community Voices programme, which we've also brought to this committee before, again, does wonderful work really, really amplifying those voices that are harder for us to hear. They are currently run rather separately, and we're proposing to the leadership of that team that we should integrate them so that we have a coordinated outreach program so that we really make the best of it, rather than lots of ad hoc short-term projects, because the Wellness on Wheels bus could do so much more if we had a bit of a long-term plan and strategy. And then the final point was to ask the committee to ratify our updated terms of reference. And there are two key changes to the terms of reference for the PHM, so Population Health Management and Health Inequalities Board. The first is that we are no longer overseeing the development of their strategies, because we have developed them, we have published them. We are now overviewing the implementation of them. That's the first change. And the second change is bringing in that oversight strategic leadership of VCSC working so that there is a home. I'm happy to take questions.
Thank you. Thank you, Frankie. Any questions for Frankie? The tours have been circulated, so we all had opportunity
there with the pack.
The full, yeah. So any further questions from Frankie? For Frankie rather than from? I can't see any hands up. Any questions in relation to the terms of reference? Can't see any hands up. So assuming there is no questions, so based on the fact that there's no questions, is the committee content to approve? Yeah, I can see the positive notes, Frankie. Thank you. On the item 42, the Wellness on Wheels and Community Voices, there are other resources which in the community which may be able to support that. Tracy is very aware of that, so probably some conversations have to be restarted to make sure that we actually spread as widely as possible to support the system to do it, and that does not require funding. So it is about talking to the right people. Is the committee content, because it's for escalation, we're happy to support the proposal of bringing together closer the community voices and Baobas. Can I see some notes? Yep, good. Frankie, thank you very much indeed. Thank you.
Excellent.
Aging Well program board update. Janice, I think it's back to you.
Actually, I'm going to hand over to James Allen. James has prepared the background information. So thank you.
Lovely. Thank you. James, welcome. You have about 5 minutes to present it and answer questions. Would that work?
That's all right, Aliona. I've been highlighting the core bits to run through, so I'll be as brief as I can.
Excellent. We do have the report in front of us, James. Remember that was circulated. So yeah.
So core aspects are reminders of the group, our work streams are prevention, dementia, frailty, attuned care, and care homes and housing. Core updates, our clinical specialty advisors for dementia and frailty have now been formally appointed. Dr. James Cass and Dr. Katie Honey at the QE, which is really important to support the clinical expertise, ground knowledge, core focuses and defining that strategy going forwards. The pilot around the clinical frailty scoring tool, the Rockwood tool, has now commenced at QE as of September, which is great news. We're just working through the metrics to analyse the impact of that tool, how it's working, if we're getting the right data feeding through to primary care, etc. We're developing a prevention comms and engagement plan for winter, and we're also looking at further into 25-26 a similar comms and prevention plan, so we've got more planning for next year. Not directly linked to the programme, but interdependent. We've successfully recruited 2 programme managers within the team in Plan Care, and one of those will be working across Ageing Well and Palliative, which is great news. So we'll be fully up to speed as a team. And then the only other core aspect I wanted to update on, which we're not taking credit for, but just to flag, the Carers Voice charity has now developed their ICS Carers strategy. We're just taking it through the Ageing Well programme to review that, so we're taking that through the dementia work stream. And then finally, in terms of next steps, if I could highlight just 2 things that we need to do before the end of year is firstly collate the findings from the Dementia Roundtable event that Frankie has already alluded to, and move to the next phase of that. And finally, developing the blueprint and the operational plan for Ageing Well as a whole, now that we have all of the governance, the work streams established and the chairs and leads in place, which is really good news. Happy to take any questions if anybody does.
Thank you, James. Thank you. So from all the work streams, if you had to think about the pieces of work which you are struggling the most with across all the work streams, what would those be?
Good question. I think realistically, it's mostly the money side of it, the funding. So a lot of the work that we're trying to doing is requiring funding. So I'd say the dementia work stream at the moment, we're still trying to get through the aspect of there's no money attached to these projects. So that's definitely one of the biggest barriers that we've got at the moment. But I think one of the core focuses we did have within the dementia work stream was the disease modifying treatments. But there's been an update on that. That guidance is no longer ongoing. I would say that primary care representation could be increased in a number of those groups at the moment. So we do have some primary care representation, but we probably need to develop that further. We now have the identified GP leads across the places that we're intending to engage with to sort of drum that up a little bit. That's a really good question. I should have prepared for that question.
Thank you, James. Well, you've answered it because the engagement would have been my second question. Are you getting traction from various stakeholders to be engaged in it? And of course, my sort of the last one will be, how are we ensuring that we get the residents, the people's voice into informing the thinking? Where do you get that intel from? And now you have different organizations around. Some of them will have good connection to our local residents, but not everyone will have that. So how do you make sure you get that input, please?
Yeah, so I think there's a couple of aspects there. I think the lived experience piece. So again, going back to dementia, part of it is getting that carer with lived experience that we can join in those groups, and this round table is part of that interlinkage there as well, so we can bring those into the group going forward. Back to engagement as well. I think care markets are an area that we need to explore a bit more. And getting care market engagement. I don't think that's quite where it should be, and that's something we can aspire to as of next financial year. We'll be trying to pull that through. The other areas in terms of education, the pieces that we're prioritising for this year are more focused on staff education pieces, but next year we'll be looking more into the patient education pack. And there's a couple of things we're doing in the palliative and end of life care space at the moment around sort of yellow folders, which is a very, it wouldn't be exactly the same, but it's something we could definitely look at in terms of aging well, because one of the core factors that I found just being in this role for a few months, is that patients don't get the right amount of information at the right time. And if we could give them a pack that tells them who to go to and what the process is going to be, that will be really supportive of patients. So I think that's, whether we take a locality-based approach or a system approach, I don't know at this stage, but I think those areas are really important as well.
Thank you. Tricia.
So, James, thank you for the mention about care homes, because I think you're absolutely right. There is so much more we can do to influence delivery of care in the care home. My second point was, I was just reflecting on this whole meeting, which I've really enjoyed, to be candid, and the discussions that have been had. Now, if we go back to dementia, if we go back to our risk register at the beginning of the meeting, and it talked about the number of years people are going to live and in poor health, although what is poor health? It all came back to me around the comorbidities and vascular comorbidities, blood pressure, the wow bust, how do we get out into communities? I mean, it's all linked. And then I thought, do many members of our public understand that their vascular status will predict for some their dementia status? They know that it will make them more likely to have a stroke or blood pressure. But I think there's a lot more that we need to do around patient empowerment around information. And I completely understand the role of health watches and the voluntary sector. But I think this is an opportunity to do something different in that space, to encourage people to either self-monitor or to get their blood pressure checked.
Mm-hmm. Thank you, Tricia. James, the last question for me is sort of assurance, reassurance. Whilst we involve people in helping us shape the future, do we have a process designed, or are we thinking about the process, how we're going to test that? So we don't just develop, implement something, and then a few months later we discover, oops, it's not quite working. So what is it that is going to help us validate that our thinking is going to work? Do we have that built into the process, please?
So I think there's two aspects to that. The first aspect, which is part of our priorities for the sort of by the end of this financial year, start of next financial year, is the development of a metrics dashboard. Not just looking at the performance metrics, but also looking at the population health data and seeing how the impact of the programs, the projects that we're doing. The second aspect is actually, as we've alluded to before, that lived experience base and bringing people in who've experienced that challenge. And bringing them into those task and finish groups, those work streams, to understand what priority work is actually supporting it, and is it working? Do they think we should be doing things differently? Because as staff, you can have a totally different perspective on what your priority should be versus somebody who's gone through it. So I think there's two aspects to that. I think we could probably do more, but I think we'd probably look to that in 25-26.
Okay, thank you. Any more questions for James or Janice? No, I see negative nods. James, well done. Thank you. Thank you for the update. And yes, good luck with the next stage of this. We'll look forward to further updates in due course. But thank you for now. Thank you, James. Okay, we came to the last bit. Any other business and meeting reflections? Any other business first? Anyone? Anything burning? No, I can't see any hands up. Any reflections from today? What did you think of us putting thematic sort of items where we can explore them in a little more detail? Kathy?
Yeah, thanks. I thought that was really, really interesting and terrifying in equal measure. I just thought, oh my God. Yeah, but really, really interesting. Thank you for that.
Thank you, Kathy. Mark?
Yeah, thank you. And likewise, but I think in the future we need to check back, as you know, answer your question. The so what, Aliona, is going to be the key bit, and absolutely, I know we'll do that. For me, what was really striking was, even though there were a number of different lenses looking at the same area, there were real common themes that, sometimes think, oh my word, this is just massive, isn't it? But actually, it'd be interesting to see the notes that follow. No pressure, Rachel, because actually, if we pick out what the key parts there is something that we can work together on to address, isn't there? So I thought that was helpful.
Thank you, Mark. And what is important, because themes will come through in all sorts of different committees, is then thinking whether that sits best with to address whatever is coming up. Frankie.
I also liked how we're properly involving place, and by having the rotating spotlight, but also having a place perspective. And people who know me well won't be surprised that I'm going to start banging on about a forward plan again. Actually, today we really focus on dementia. So what are we focusing on next time, and the time after, and the time after? Because these meetings do take a lot of work. And it is really useful, if the maternity team know that next month it's maternity, and the children and young people team know that the month after, or the month after it's going to, whatever it is we're doing, so much it's so much easier for all involved if we can set that for the year.
Yeah. Thank you, Frankie. All very useful. Thank you so much to every single one of you for your contributions, thinking, curiosity, and so on, for your participation. Our next meeting is on the 25th of November, is a Monday at 2:30. So thank you again. Committee members only, we are going to rejoin within a few seconds after logging out of this for a short meeting for half an hour, please. Thank you so much to all for presenters and listeners and the committee. See you all next time. Take care. Thank you.